Imagine for a second what happens when someone swallows a corrosive substance, like a drain cleaner or a strong acid. It kicks off this absolutely devastating chain of events inside the body. This is called caustic ingestion, and it is a true life or death medical emergency. We're going to walk through exactly what happens from that first instant of injury all the way to the lifelong battle for recovery. And just to set the stage, the stakes could not be higher. A person who survives a caustic burn to their esophagus faces a 1,000 to 3,000-fold increase in their lifetime risk of developing esophageal cancer. That's just a staggering, mind-boggling number that hangs over their entire recovery. So here's how we're going to break it down. We're going to follow this journey through 5 critical stages. We'll start with the injury itself, then see how doctors figure out the damage. After that, we'll look at how they stabilize the patient, when they have to make the call for surgery, and finally, what that long road to recovery really, truly looks like. All right, so let's get right into it. What is actually happening in those first few seconds after ingestion? Well, it all comes down to the chemistry, how the specific substance reacts with living human tissue.
You know, there's a huge difference between an alkali burn and an acid burn. Alkalis, the kind you find in drain cleaners, cause something called liquefactive necrosis. That means they literally dissolve tissue, turning fats into soap and just destroying cells, which lets the chemical just keep going deeper and deeper. The damage is extensive, and it's almost instant. Acids, on the other hand, they cause coagulation necrosis. Think of it more like searing a steak. It forms this hard, protective scab that, thankfully, often limits how deep the burn can actually go.
But the damage doesn't just stop with that initial burn. Oh no, that's just the beginning. Over the next few days, all that dead tissue starts to slough off, creating these incredibly painful ulcers. Then, around 2 weeks, the body starts to panic and lays down this thick scar tissue. That's called fibrosis. And this is where the real long-term problems start, because over the next few months, that scarring can shrink and contract, causing what are called esophageal strictures. It basically narrows the food pipe so severely that it becomes difficult or sometimes even impossible to swallow. So, the patient is in the emergency room and the clock is just ticking. The next crucial phase is to figure out exactly how bad the internal damage is, because what you see on the outside can be dangerously misleading. The ER team has a very systematic process. First, the history. What do they swallow, how much, and when? Then a physical exam, looking for obvious burns and any signs of a perforation. But here's a critical and, frankly, terrifying fact. Up to 20% of patients who have severe internal injuries show absolutely no visible burns in their mouth. And that's why the CT scan is so vital. It lets doctors see through the wall of the esophagus and stomach to figure out the true depth of that chemical burn. Now, once the patient is stable enough, the gold standard for really assessing the injury is an endoscopy. Doctors use a grading system, it's called the Zargar classification, to look directly at the tissue and classify just how severe the burn is. This isn't just about diagnosis, this is a powerful tool that helps predict the patient's entire clinical course and their risk of future complications. You can see the progression so clearly here. Grades 0 to 2A, those are considered lower grade injuries, and the prognosis is pretty good. But the real turning point is grade 2B. This is where the ulcers are deep or they wrap all the way around the esophagus. Patients with grade 2B injuries have a 70 to 100% chance of developing those debilitating strictures we were just talking about. By the time you get to grade 3, you're looking at necrosis, dead tissue, which carries a very, very high risk of perforation and death. And here is what that damage actually looks like. On the top left, that's a grade 1 injury. It's just some redness and swelling. But as you move across and down, the damage just becomes horrific. By the time you get to those images on the bottom right, that's a grade 3B injury. The tissue is literally blackened and dead. This is what doctors are up against, and this visual evidence dictates every single decision they make from this point on.
Okay, so with a clear picture of the damage, the focus now shifts to stabilization and supportive care. And what you don't do is every bit as important as what you do.
Let me be crystal clear about this. It is absolutely critical to avoid these 3 things at all costs. Making the patient vomit is catastrophic because it just re-exposes the already burned esophagus to that corrosive agent. Trying to neutralize an acid with a base, or the other way around, that is a terrible idea. The chemical reaction releases this intense heat, which adds a severe thermal burn right on top of the chemical one. And trying to blindly place a feeding tube risks poking a hole right through the weakened, fragile esophageal wall. So, instead of doing any of that, the management is all about support. Priority number 1 is protecting the airway, which might mean intubation if there's swelling. Then you hit them with aggressive IV fluids to manage shock, give medications to suppress stomach acid, provide strong pain control, and of course, keep the patient from eating or drinking to let those injured tissues rest. This is really the foundation of their care. But supportive care isn't always enough. For the most severe injuries, the only choice left is emergency surgery, a decision that has to be made incredibly fast to save the patient's life. The criteria here are clear, and they are absolute. If that CT scan shows transmural necrosis, which means the burn has gone through the entire thickness of the esophageal or stomach wall, that patient is going straight to the operating room, no debate. At that point, a perforation, a complete tear, is basically inevitable. Waiting is not an option because it leads to fatal infections like mediastinitis, an infection in the chest, or peritonitis, an infection of the abdomen.
And the surgeries themselves, these are massive, massive undertakings. The most common emergency procedure is an esophagogastrectomy, the complete removal of the damaged esophagus and the stomach. Months down the road, if the patient recovers, surgeons can try to reconstruct the digestive tract. They often do this by using a piece of the patient's own colon to build a brand new esophagus. These are just life-altering procedures that really underscore the sheer devastation of that initial burn. For those who survive this acute injury, whether they had surgery or not, the journey is so far from over. Life after a caustic ingestion is a lifelong battle with the consequences. This slide really breaks down the most common long-term issues. The biggest one by far is esophageal strictures. That's what causes the debilitating difficulty with swallowing that often requires repeated, painful procedures to stretch the esophagus back open. You can also see fistulas, which are abnormal connections between the esophagus and the airway. And then there's the ever-present shadow of cancer. This quote just puts it in such stark terms. That initial chemical burn starts this process of chronic inflammation that can lead to cancer decades down the road. The average time? 41 years. That means these patients need to be monitored with endoscopies for the rest of their lives.
And this all brings us to a final, really crucial question. We've seen the absolutely catastrophic medical journey that follows one of these injuries. So, knowing the immense suffering it causes, and knowing that these incredibly dangerous agents are just sitting in everyday household products, we really have to ask, what more can be done to prevent these tragedies from ever happening in the first place?